Good morning, friends. Today, I'd like to share an interesting clinical case that beautifully illustrates the practical value and limitations of observing nystagmus during Epley maneuver in posterior canal BPPV. Benign paroxysmal positional vertigo remains one of the most common vestibular disorders, and the Epley maneuver is our first line treatment. While its overall success rate is high, typically around 60 to 90%, a significant minority of the patients require repeat maneuvers or do not immediately respond. This raises an important clinical question. Can the nystagmus we observed during the maneuver reliably predicts the success? A recent 2025 study by Hiroaki Ichijo and colleagues published in Acta Oto-Laryngologica directly addressed this. They prospectively observed eye movements in 50 consecutive cases of unilateral idiopathic posterior canal BPPV using infrared video-oculography. The key findings from their work in the critical healthy ear down 135-degree position, which is the position 3 you see on the screen of this patient with left apple maneuver. So they found that 62% of the patients showed torsional nystagmus beating towards the affected ear, that is the affected left ear in this case. This group had a high success rate of around 93.5%. 12% showed nystagmus towards the healthy side. This is group B, and 66.7% had success. 20% showed no nystagmus in that position. That is the position 3 that you see here, and this was the group C. Yet surprisingly, they achieved 100% success. So nystagmus in the final sitting position was seen rarely, only in 6%, even though the debris is presumed to be stimulating the utricle. This led authors to conclude that nystagmus during the maneuver is helpful but not always predictive, and that the utricular stimulation does not reliably produce the visible nystagmus. These case results highlight both the utility and variability of the nystagmus observation, exactly what we encountered in today's case. So my case is a 62-year-old female with a classic left posterior semicircular canalolithiasis with typical upbeat torsional nystagmus during the left distal pike testing with latency and fatigability. During the initial left apply maneuver, we carefully monitored all positions, notably in the 135-degree right ear down position. We did not observe the expected torsional upbeat nystagmus towards the affected left ear. On subsequent repeat apply maneuver in the position 1 had turned 90 degree towards the healthy side, roughly equivalent to the left distal pike orientation. We saw downbeat right torsional nystagmus, a reversal pattern suggesting the first maneuver had been incomplete. Then, in the key 135-degree healthy ear down, that is the step 3, torsional upbeat nystagmus beating towards the affected left ear was finally evoked. Immediately afterward, the repeat distal pike test was negative, confirming the successful repositioning. This case demonstrates several points aligned with the Ishijo's findings. Absence of nystagmus in the 135-degree position on the first attempt did not rule out the need for or eventual success of the repeat maneuver. Observation of the correct direction torsional nystagmus in the third position ultimately correlated with the therapeutic success. Reversal of the typical nystagmus patterns can appear when the debris has not yet fully mobilized, reinforcing the value of real-time monitoring and willingness to repeat the maneuver. In summary, while nystagmus observation during the apply maneuver provides valuable real-time feedback, it is not infallible. Our case adds to the growing literature showing that the persistence and careful technique remains essential, and that even the silent or atypical maneuvers can succeed. I will not now walk through the video recordings of the nystagmus patterns and step-by-step maneuvers on the following slides. So this is my title slides, Nystagmus monitoring during the apply maneuver and predicting the treatment success. This is the article by Hiroaki Ichijo and Hisao Ishiji published in 2025 in the journal Acta Oto-Laryngologica. Here they found that a high incidence of torsional nystagmus towards the affected ear was observed in the healthy ear down 135-degree position occurring in 62% of the cases. This finding indicates that the treatment was successful. However, not all cases exhibiting nystagmus achieved complete recovery. 94% of the patients did not exhibit nystagmus in the final position, even though the pathological debris was stimulating the utricle. So they concluded that the nystagmus finding during the Epley maneuver cannot always predict the efficacy. The occurrence of nystagmus in the final position is very low, suggesting that the stimulating the utricle may not always induce nystagmus. So this is the first Epley maneuver. The step 1 of the Epley maneuver is equivalent to the left distal pike testing. It evokes after a short latency left torsional upbeating positional nystagmus, which was non-persistent, lasting less than a minute. So we waited in the left distal pike position to make it the step 1 of the left Epley maneuver. And as we waited, we saw a nystagmus which was downbeating and right torsional appeared after cessation of the initial upbeating left torsional nystagmus. This nystagmus is slow crescendo decrescendo, that is an inhibitory nystagmus, and possibly it signifies that the debris is returning towards the ampulla, that is causing the ampulopetal deflection of the left posterior cupula. So in the position 2 of the Epley maneuver, the eyes showed a few beats, possibly right torsional and downbeat, but not very clear. I would pass this as a normal in the position 2. We maintained this position for a minute, completing the second step of the Epley maneuver. So after the step 2 of the Epley maneuver, the patient was transitioned right little recumbent with nose down. And as you can see that there's hardly any nystagmus in the position 3 of the Epley maneuver, which was maintained for full 1 minute before we uprighted the patient to short sitting position, completing the first Epley maneuver. Having monitored the all 3 steps of left Epley maneuver. So a immediate left distal pike retest was planned. What probably occurred during the initial left Epley maneuver, this is the video frontal recording of the second Epley maneuver. This is in fact the left distal pike retest, and as you can see that there is a slow crescendo decrescendo downbeat right torsional positional nystagmus, indicating that the debris is moving ampulopetally. That signifies that the first Epley maneuver had failed. So we continued the left distal pike retest with the position 1 of the left Epley maneuver, The right torsional downbeat nystagmus was non-persistent, but this was a classical inhibitory nystagmus denoting movement of otoconal debris in the left posterior semicircular canal towards the ampulla, causing ampulopetal deflection. In the step 2 of the Epley maneuver, there was hardly any nystagmus. The step 2 of the Epley maneuver was maintained for a minute, after which the patient was positioned right lateral recumbent with nose down, making it the 135-degree step 3 of the left Epley maneuver with healthy ear down. And as you can see that there is a upbeat left torsional positional nystagmus in the position 3 of the left Epley maneuver, that is with the healthy ear down and 135-degree head rotation from the left dixal pike position. In the Ichijo series of 2025, 93.5% they had responded successfully. So we in fact expected that this patient would favorably respond, and indeed during the left dexalpike retest after the second Epley maneuver, the patient was asymptomatic and did not evoke any nystagmus during the left dexalpike testing. So what happened after the first Epley maneuver? The otoconal debris, it moves ambulofugally initially, generating upbeating left torsional positional nystagmus. However, it had fallen back, probably in the non-ampullary arm or even in the periampullary location. And during the subsequent left Epley maneuver's first step, that is the left dixalpike retest, the otoconal debris, it moved ampullopetally initially, causing the nystagmus which was right torsional and downbeat, and then it moved into the utricular macula, and thus the patient was cured. So this is how we monitored the nystagmus, and we could find that in the group A of the patients of the Ichijo series, which had 93.5% success rate in the patients evoking upbeat nystagmus with torsional component directed towards the involved ear. This was around a 93.5 success in his series, and this was the same patient who had succeeded after showing this form of nystagmus. So I finish my talk here. Thank you very much.